Hello, everyone. We are just waiting. The session 2 webinar will begin soon. Thank you for your patience. We're just working to get everyone admitted from the waiting room. We had a rather large attendance for today, so just give our co-host a moment as they work to get everyone admitted. Attendees will remain in listen-only mode. If you have questions or comments, please use the chat or Q&A for those comments and or questions. Will work. It looks like our co-hosts have nearly everyone admitted. So with that, I will get started with introducing our speaker for today. Hello, everyone, and welcome. Thank you for joining again as we are moving into our conference session number 2, Coding About the Pelvis with Dr. Miller. Dr. Anna Miller grew up in Texas after graduating Rice University with honors in biology. She went on to graduate from Baylor College of Medicine. She currently works for Washington University of Orthopedics. Dr. Miller, has a national reputation for her achievements and leadership activities. She was a recipient of the 2015 American Orthopedic Association North American Traveling Fellowship. She is active in the Orthopedic Trauma Association, including the research committee, and serves as an associate editor for the Journal of Orthopedic Trauma, the leading musculoskeletal trauma journal. Recently, she was elected the chair of the AIS Content Committee for the AAAM. She was a leadership fellow with the American Academy of Orthopedic Surgeons in 2017 to 2018 and has been selected to be a 2022 American Orthopedic Association American British Canadian Traveling Fellow. Dr. Miller has particular interest in the improvement of orthopedic trauma care on a national level and is the chair of the orthopedic subgroup for the ACS COT. And these are only the tip of all of her interest, as well as work for trauma and injury care. We are very fortunate and appreciative of Dr. Miller taking time out of her schedule today to talk to us about coding with the pelvis. With that, I will stop sharing my screen and I will turn it over to Dr. Miller and bring her on screen to be able to start sharing her screen.
Thank you very much. That was a very nice introduction. Much appreciated. So let's see if this works. Can you see my screen?
Not yet.
Unfortunately, I don't use Teams very often, so.
Yeah, I think last time the way the speaker ended up doing it, she used share and then share all, and it helped share her screen.
Okay, let me try that.
We are still trying to get people admitted from the waiting room as well, so.
Is that working? It says I'm presenting.
It is. Yes,
okay.
ma'am.
Wonderful.
We are able to see all of that. I will mute and let you go ahead and begin your presentation. Again, thank you so much for your time today.
Thank you. Unfortunately, you can still hear the beeps of all the people coming in, so hopefully you guys can just ignore that. I can't mute that part. So thank you for having me again, and appreciate the introduction. And I am going to go over pelvis and acetabular fracture coding, which I know is one of the more complicated orthopedic musculoskeletal coding issues. I am happy to be interactive if you guys want to ask questions, but I'm not going to be able to monitor the chat. So Amanda, would you mind being in charge of that if there's questions that come up?
Absolutely. If you have questions as we go through, if you will put those in the chat and the Q&A, myself and the two co-hosts will make sure to monitor those, and we'll ask those at the end if that is okay, Dr. Miller.
That's perfect, but feel free to interrupt if there is something that needs to be asked more urgently.
Sure. Thank you.
All right, so today we're going to go over a little explanation of the anatomy because I think that is essential to really understanding the pelvis and acetabulum. I'm going to briefly go through what really good x-rays should look like because I do think we get a lot of, unfortunately, not very good x-rays because our patients are traumatized in the ED and they're not always in a good position to take the time with proper imaging. And then I will go through the pelvis classification and the acetabulum classification with our coding, and then kind of correlate that with the classifications that we use that you may see if you're looking at an op note or other, maybe a radiology read. And then if we have time, I'll go over some case examples at the end. But if we're running out of time, then definitely we'll prioritize your questions and do the Q&A over the case examples. So just a little explanation of the anatomy. The pelvis, as you all know, is very confusing. But if you think about this as three separate bones, I think it's a little bit helpful. So they're the two innominate bones. Can you guys see my mouse pointer? Okay, great. So the two innominate bones are the two bones on the side that connect with the sacroiliac joint to the sacrum, and then there's the sacral bone, which is the sacrum in the back. And then those three bones also connect at the symphysis in the front. So there are actually three separate bones that are connected just with ligamentous structures. And that is really important because there's not actually a bony connection like there are in some of the joints we have in our body. And it's really important to remember that there are a lot of ligaments that connect the pelvis and particularly the sacrum and the spine. So you can see in this drawing, the spine kind of ends at the top of the sacrum, and then there are a bunch of ligaments attaching the two. So a lot of times you guys may see coding for a sacral fracture or a pelvis fracture, but also a lumbar spine, especially you see these transverse process fractures. And a lot of times that is actually because when the pelvis ripped or tore or fractured, it pulled that lumbar spine with it. So really just important to kind of think about it as a whole with the spine, the sacrum, and the pelvis all as kind of part of one unit. The back posterior ligaments. This is the sacrum, so this is kind of looking at it in an axial cut now. The sacrum and the ilium, or those two innominate bones we were talking about, are connected with the strongest ligaments. So the strongest ligaments in the body are these posterior iliosacral ligaments that it's kind of showing here. And I bring that up because when we see posterior injuries to the pelvis, which we'll talk about more when we get to the coding part, a posterior injury denotes a really higher level of energy, which is why they have a higher level code, because these are the strongest ligaments. So if there's any injury, either a fracture or a tear of the SI joint in the back, that's when we know it's a more severe injury. And that's also important because that's kind of where the energy goes when you're just doing all your normal activities of walking and moving around. And that happens because the sacrum basically acts like the keystone. You may have heard the term the keystone of an arch. So when you look at the pelvis, the sacrum is like the keystone of the arch. So if you imagine your weight coming down from the spine onto that sacrum, and then it forms the arch down to the legs. So that whole posterior part of the pelvis, the sacrum and the SI joints and those very strong ligaments are actually the keystone of the pelvis. And again, that's why we care a lot more about posterior injuries, because that is where the most important part of the pelvis stability is. And this is just another example of the same thing. So this is just a regular skeleton like you might see in your doctor's office. But if you're standing upright, you can imagine that as you're standing, your body weight essentially comes down the spine and lands on top of that sacrum. But then it kind of arches along the pelvis to your legs. So you can see from looking at this that all of the weight and the force that goes through the pelvis is mostly in the posterior part, and then going down to the legs through the acetabulum. And we really don't worry quite as much about fractures in the front of the ring because they're a little bit more inessential joints. They're still critical for overall pelvis stability, but here you can really see why the posterior part of the ring is the critical part. And if you look at this, they've actually done studies where they figured out how much load or force was going through each SI joint. So when you're sitting down or lying down, the forces are a little bit lower lying for sure. But if you're sitting or if you're lying on your side, those forces go up from 200 to about 700 newtons. And then when you stand up, the force goes up to almost 1,000 newtons. So the SI joint in the back really takes a lot of force with all of your daily activities, especially just standing. But you can imagine this would be even higher if the patient was running or jumping or something like that. The other thing to remember about the pelvis, and this is again one of the reasons it's so important and really critical in injury coding, is that there are a lot of structures that run through it. So this is kind of a slice down the middle in the sagittal plane, and it really shows just one half of the pelvis, all of the arteries. This is, of course, the aorta coming down, but then the external and internal iliac arteries. All of the nerves come through the sacrum, which we'll talk about in a second. And then, of course, the venous plexus also, along with the rectum and the bladder, and of course in women the uterus, all in that area. So very common to have injury to these other internal structures at the same time, which again will become important when we talk about the coding. One thing to think about is when we talk about the fracture patterns, depending on how the patient broke their pelvis, they have a higher or lower risk of bleeding. So we know if the pelvis is crunched in, so with lateral compression, it's a little bit lower vascular injury risk. If the pelvis is ripped open, so we call it an APC, anterior posterior compression, or where the symphysis is torn open, then it has a higher risk, which makes sense because as you pull the pelvis open, you're putting all of those neurovascular structures on tension. So they're a higher risk of having some injury than you are if you compress them just a little bit. So there are a bunch of different classifications for the pelvis. We're not going to go through all of these in detail, but the really, really important thing to know about the pelvis, and this goes into what we'll talk about later with the injury coding, is whether the pelvis itself is stable or unstable. And in general, an unstable pelvis has a complete injury to the posterior part of the ring, which is, again, why I'm trying to emphasize the importance of the posterior ring injury. But if you don't have a posterior injury, then the pelvis is probably stable. If you have a posterior injury that is incomplete, then it is probably stable. But if it's a complete injury all the way through the posterior part of the pelvis, then it probably is unstable, and that gives it a higher level of concern for bleeding, concern for the patient, and of course, a different level of coding. I also mentioned briefly the neurologic structures, and this is another just picture of a pelvis, and the black lines here are the nerves that come through the pelvis. So L5 nerve root comes over the top of the sacrum, and then S1, S2, and S3 kind of come through this foramina in the sacrum. So you can imagine, again, if there's a fracture in this area, like shown here with the red, those nerve roots are at risk, especially again if there's distraction or the pelvis is pulled apart, then those nerves are more at risk. We know actually, depending on where the sacral fracture is, that you can increase the level, the percent chance of injury. So if the fracture is way over here, away from the nerves, it has only about a 6% chance of injury. If it's through those foramen where the nerve roots are coming, about a 30% chance of injury. And if it's medial to that, so farther over, then it's up to a 60% chance of injury. So very important to kind of figure out exactly what structures we're concerned about. But again, this may be something that you see when you're looking at CTs or MRIs. The radiology report may say things about the nerve injuries related to these fractures. So one thing I think is really, really critical, and we have a really hard time conveying this to people outside of orthopedic surgery, but we're not even very good at conveying it to our own residents. So hopefully I can kind of convey this point that a pelvis injury and an acetabulum injury are not the same thing, which is really confusing because the acetabulum is a part of the pelvis, but it is not a pelvic ring injury. So when you're thinking about coding, the main thing to distinguish is the entire pelvis disrupted where that spine connection to the femurs is disconnected, or is it just an injury right in the acetabulum hip socket area? And unfortunately, some of the acetabular fractures in the hip socket area can crack all the way up to the top of the iliac crest, which makes it a little confusing. But what we really want to focus on, just like I said before, is that posterior ring injured? Is there a sacral fracture, an SI joint injury, a posterior iliac wing fracture that's disrupting that posterior part of the pelvis? So remember, the acetabulum is just focused around the hip socket, and hopefully I'll clarify that a little bit more later. So this is the original Le Tournelle is one of our French orthopedic surgeons who about 100 years ago described the 10 types of acetabular fractures. And this gets extremely confusing for multiple reasons. Number one is that they always have these drawings of the acetabulum, which I think are really confusing because it shows them from the side, like this 3D image, and we never look at x-rays from the side like that. So why they decided to draw it like that and confuse us all, I think is very strange. But the point is that, as you can see here, every single one of these fracture types, all 10 of them, fracture in the joint itself. And you can see that none of them are going back here, which is to the back of the pelvis area. So these are the acetabular fracture types, which again, we'll talk about a little bit more with a coding later, as opposed to the pelvis fractures, which are more related to how concerned we are about the symphysis and the SI joints and the sacrum. So this is just one example of a patient who you might find very confusing if you looked at their x-rays about whether this is a pelvis fracture or an acetabular fracture. So what I encourage people to do is first decide if this is a good image or not, which we'll talk about in a second. But if you draw a line kind of down the center of the patient in your mind, and then you can kind of draw a line across the top of the iliac crest, that kind of gives you an overall idea of whether things are even from one side to the other. And in general, if you look at this, things are pretty even from one side to the other, except for this area right around the hip socket. And because these are not very good x-ray images, I also have a 3D CT, which I'm just going to play this a little bit, hopefully, so you guys can see. There's a fracture line here. There's a fracture that kind of goes through the socket, and then there's another fracture line here. So keep an eye on that. If you pause it right here, you see there's nothing in the back of the pelvis at all that's broken. And if we turn it this way, what you see is that this acetabulum part is a separate piece, but the whole rest of the pelvis is intact. So even though this is a really bad acetabular fracture, this is just an acetabular fracture. It is not an injury to the rest of the pelvis. which again can be very confusing. But if you really try to focus on whether, especially that posterior part of the pelvis is intact, that's the really, really important thing. So one other thing just to think about when you're thinking about the acetabulum is this concept called the two-column concept. So this comes into play a little bit with the coding, and I'll just explain a little bit. Again, like that drawing that I showed earlier, this is supposed to be a picture of the acetabulum from the side, and they call this the inverted Y. And basically what it's trying to show is that if you imagine, again, this is the Y, it's very confusing, but the acetabulum is in the middle, and the anterior column of the Y consists of the ilium and the pubis, and then the posterior column consists of the ischium. So if you imagine the Y coming down here with the acetabulum right in the middle, that's how we get this idea of the columns. And again, that posterior part of the pelvis is not involved at all. So even though you can have big extension all the way up into the iliac wing, we're not having pelvis fractures with these acetabular fractures. So when we start talking about coding, we are going to talk about whether this is a 1 or 2 part injury. And these are what we're talking about when we talk about the columns and those types of fractures. So the anterior column, again, this is looking at it from the side like I showed before, is from the symphysis to the anterior part of the acetabulum and up to the anterior inferior and anterior superior iliac spine and up to the iliac crest. The posterior column is the ischium past the lesser and up to the greater sciatic notch, and that is the posterior column. This is another view of the same thing, just showing it from the inside of the pelvis, which again, we never look at the pelvis this way on x-ray, but that's just to show you the anterior versus posterior columns.
Dr. Miller, I'm
Yes.
sorry to interrupt. Are you still using your pointer to point at anything on the slides? Yes, ma'am.
Yeah. Can you not see it?
We are not seeing that. I'm getting reports that they're not seeing that. I'm not sure if we even have the ability to show it.
I think I can try this. Okay, can you see this now?
Yes.
The laser pointer?
Yes, we can see that. Can everyone see that? I know I can see it. I see the hand that was raised go down, and I'm getting yeses.
Okay, so let me just go back, because this is just briefly to reiterate. Okay. This is the acetabulum. This is the inverted Y. Thank you for that. So this is the anterior column, this is the posterior column. So if you imagine that on here, this is the acetabulum, this is the inverted Y, so this is the anterior column, this is the posterior column. And on this view, inverted Y, anterior column and posterior column. So basically, anterior column is from the symphysis to the acetabulum up to the AII and ASIS, up to the iliac crest. And then the posterior column is the ischium through the lesser and up to the greater sciatic notch. So this is only important when we get to coding later, because there are different codes for more complex fractures. But this is what they're talking about when they talk about an anterior column or a posterior column fracture. So basically it would be a fracture from the acetabulum through the posterior column or through the anterior column. But again, you can see on all of these diagrams, there's no involvement of that posterior part of the ilium, where the SI joints and the sacrum and everything else related to the pelvis are. So again, just acetabulum, not pelvis. So this is also a little bit confusing, and I'll go over this on a real x-ray in a minute, but these are the lines we look at on an x-ray to be able to figure out which kind of fracture it is. And this seems a little antiquated now because we get a CAT scan on basically everybody. But when we first started looking at acetabular fractures, or when my predecessors first started looking at acetabular fractures, they really only had good quality x-ray. So they really had to distinguish these lines on x-rays that you might not be able to see very well, but they didn't have quality CT like what we have now. So if you look at this, and again, this is a 2-dimensional representation of a 3-dimensional structure. So it's very confusing, but remember that the sacrum, The SI joint, the ilium, these are posterior structures that are part of the pelvic ring, whereas the symphysis here and the superior pubic ramus are the anterior parts of the pelvic ring, and then the acetabulum is kind of in between. So when you look at these numbers, the iliopectineal line basically goes along the anterior column and above the brim, the superior pubic ramus, into the symphysis. The ilioischial line goes again from the greater sciatic notch area down along that posterior column. So even though it looks like a flat line here, remember it's actually a posterior structure down to the ischium. Number 3 is the teardrop, which is a really radiographic view of the inner and outer tables of the medial side of the acetabulum. The dome is the weight-bearing surface of the acetabulum. And then when you hear about the anterior and posterior wall of the acetabulum, the green here is the anterior wall and the red is the posterior wall. So on this previous drawing, this would be the posterior wall and this would be the anterior wall. But on an x-ray, this is what they look like because you're looking at it front on instead of from the side. So this is another drawing of the same 6 lines, but you can see it can be really, really hard to see them, especially this is actually a scout view from a CT. It's not a real x-ray, so those lines can really be hard to see. So I've drawn them in black over here. And then this is just one more example with a real x-ray. So number 1 is the iliopectineal line, which is the anterior column coming towards us out of the x-ray. Number 2 is the ilioischial line, which is going posterior down the posterior column to the ischium. Number 3 is the teardrop, which is that medial wall on the medial surface of the acetabulum. Number 4 is the dome, or the weight-bearing surface of the acetabulum. Number 5 is the anterior wall, which you can just barely see on this other side here. And then the posterior wall is actually a little bit sticking out because the angle of the acetabulum, the anterior wall, looks a little bit more medial than the posterior wall on the x-rays. So these are just some radiographic correlations of what the anatomic structures are that we see. So I'm going to go over some x-rays of like what good x-rays look like just for a few minutes, but I just want to mention you might have heard of Judet views, or you may see this written in a report. And a Judet view, this guy Judet was the French orthopedic surgeon I was referring to earlier, who basically invented the modern way we look at acetabular fractures. And what he realized was just getting one AP x-ray was not enough information. Like every x-ray, we need multiple views. And for the acetabulum, it helps to have angled views. So this is the cross-section of the body. Basically, we tilt the patient up to 45 degrees and then shoot an x-ray through. And then we tilt them the other direction, 45 degrees, and shoot an x-ray through. And this is what the x-rays look like. It's kind of weird, but when you tilt them over, you get a much better look at the obturator ring. And on this view, you can see the anterior column really well, and you can actually see the posterior wall a little bit easier. Whereas when we tilt them the other direction, you can see the posterior column really well, and then you can see the anterior wall a little bit better. So that is what the Judet views are for. So just to go over what good x-rays look like in case you're ever looking at x-rays and wondering what's good and what's not. So this is not a good AP x-ray because the tip of the sacrum does not touch the top of the symphysis and the spine does not line up with the symphysis. So if you want to draw those lines, you should really have a perfect line down the spine through the center of the symphysis, and the tip of the sacrum should basically touch the top of the symphysis. So that's how you know you have a really good AP x-ray. We also get special views called inlet and outlet views for the pelvis. And these are views to help discern the anterior-posterior translation of the pelvis. So this is not a good inlet view, but in general, we should look, the sacrum, you should be basically looking directly down on it. You should not be able to see it as well as you can here. And again, the spine should be lined up with the symphysis. So if you angle that here, you see that the front of the sacrum is dead on. So you're looking straight down on the top of the sacrum. The posterior ilium is lined up really nicely, and the symphysis and the spine are lined up nicely. So this is a really good inlet view. From this, we can really tell if you look at the SI joints or the posterior pelvic ring, if everything is equal from side to side. The outlet view is the opposite of that. So in this one, we're trying to look straight at an AP of the sacrum. So you should really be able to see the entire sacrum. And to do that, you have to tilt the pelvis way up. So the top of the symphysis should actually be all the way up at the second sacral foramen. So this is what a good outlet view looks like. And here you can see the full outline of the entire sacrum. So it's an AP of the sacrum. And then to do that, you line up the top of the symphysis with the S2 body just below the S1 foramen. And then that posterior ilium should be lined up, and the symphysis and the spine should be perfectly lined up. So we don't often get these really good x-rays, but that is the goal of what we're looking for. And then the Judet views that I was talking about a second ago, where we tilt the patient up 45 degrees. Most of the time the patients have an injury. They don't want to be tilted up 45 degrees. It's very uncomfortable for them. So most of the time we get x-rays that are not as tilted as they should be. So here you can see it needs more rotation because the tip of the sacrum on a good Judet view should be overlapping with the femoral head. So you can see here, if you tilt it even more, the tip of the sacrum coming down should be overlapping the femoral head. And here the ilium is lined up nicely. And now we can see those landmarks I was talking about earlier with the anterior column. And then this is the posterior wall. And then if you do the other direction, again, looking at that same side, you see the posterior column really nicely. And now we can see the anterior wall really nicely. And you can see, if you look closely, that the Judet view of the right side is the opposite Judet view of the other side. So this is what we call an obturator oblique view of the left side and an iliac oblique view of the right side. But the opposite one is the obturator oblique view of the right side and the iliac oblique view of the left side. So you're always getting the Judet views of both sides. It just depends which one is injured that you're looking at. Okay. Sorry, I don't know why these are all in there twice. Ignore these. Okay, so now we're going to move on to classification. Any questions about that radiographic correlation section before I move on?
Just a moment, let me look. I know that people were having trouble with the Q&A. Just use the chat function until I can determine the functionality issue. I do not see any coming in on that. Well, nope, but thank you for the explanation.
Okay.
Okay.
So I'm going to go over classification a little bit. And this is a document that I got some of the pictures from. This is the official orthopedic trauma classification. The AO and the OTA are our two main orthopedic trauma groups, and they came together and created this classification for every fracture there is. So all of our AIS coding is essentially based on this classification. So they kind of go hand in hand. So if you want to look at more information or more detail about certain fractures, this is where you can find everything. And if you just Google AO-OTA classification, this will pop up if you can't write down the whole website. So the pelvis classification, like we mentioned earlier, the pelvis fracture classification is related to how much potential hemorrhage that they may have. So these are the three main types of pelvis fractures. So the first row is a lateral compression type of injury. The second row is an APC or anterior posterior compression type of injury. And the third row is a vertical shear type of injury. So I just want to go back for a second and talk about APC because I think it's one of the stupidest names. not, I think you guys have noticed by now, I'm very blunt about my feelings about things, but I feel like we should all be as clear as possible and explain things as succinctly as possible. And to me, anterior posterior compression does not explain this injury very well because we all call it an open book fracture, which open book makes perfect sense to everybody. But basically, what they thought was if you have an anterior to posterior vector force, so that's what this arrow is representing. So if you're riding a motorcycle and you hit the gas tank, is a very common way we see these, the pelvis splits open from the front. And as that frontal anterior posterior compression force happens, it splits the pelvis open like a book. So I think that APC term is very confusing, but that is the explanation behind it. So in the first row, you can see in all of these, the injury vector is coming from the right side of the screen to the left. So that's lateral compression, which I think is very a term that makes a lot of sense. And when that happens, the pelvis kind of folds in. So these are from least to most severe types of lateral compression injuries. In the second row, these are all that frontal force. So the anterior posterior compression, again, least to most severe types of injuries. And if you look really closely, this is subtle, but you can see on the least severe injuries, there's always an injury in the front, but there's no injury in the back. And same here, there's an injury in the front, maybe a tiny little hairline crack in the back, but not anything all the way broken through. Whereas the more severe injuries, you can see there's a complete break all the way through the back here. And on this one, there's even a little injury on the opposite side. This number 2 on the APCs, there's a complete injury through the SI joint here, and even bigger complete injury here. And then on the vertical shear, which is the most severe type of fracture, there's a complete injury all the way through the front and the back. So this, we think the most common mechanism would be, for example, somebody who jumped out of a building and then they hit the left side and it broke their pelvis off and sheared. So that's why they call it a vertical shear. So essentially what we want to know about the pelvis for coding is, again, is there a complete posterior ring injury, a partial posterior ring injury, or no posterior ring injury? Because the front is injured in every single case. It's kind of like if you sprain your ankle, you're always going to tear a tiny bit of a ligament, but what we want to know is, did you tear all of the ligaments? So this is the AIS coding rules for the pelvis, and I'm not going to read this whole thing, but the first thing it talks about is that the acetabulum and the pelvis are two different things, which we already went over. The second part is the pelvis ring. It says it has 2 arches. The posterior arch behind the acetabulum and includes the sacrum, SI joints, and their ligaments, and the posterior ilium. So that's that posterior part we were talking about. The anterior arch is the pubic rami and the symphyseal joint pubis. And then this is the most important part. The severity of a pelvic ring fracture is directly related to the extent of damage to the posterior arch rather than solely to which anatomic components are involved. So that's what I've really been harping on, that posterior ring. And the 3 basically things that you should think about are what's at the bottom here. The stable, partially stable, and unstable. So stable is easy because we already went over that there's no fracture in the posterior arch, so therefore it's stable. There sometimes can be some, maybe a little bit of soreness or something in the pelvic floor for the patient, but the ligaments are intact and able to withstand normal physiologic stresses without displacement. So most of these people, we let them weight bear as tolerated, although it is BEAR. Partially stable, I could go on and on about the typos, so I will try not to. I'll try to control myself in the tangents, but as somebody on the AIS committee, I have really tried to correct these typos. The partially stable means that the posterior ligamentous, so this says osteoligamentous, which means the bone or the ligament, they have partially maintained integrity and pelvic floor intact. So what this means is that you could have partial fracture that's not all the way through, or a little bit of ligament damage, but not all the way through. And then unstable means complete loss of posterior integrity. So that means the fracture or the ligament SI joint is torn all the way through. So the most important thing is, again, stable or unstable. Frozen. Okay, so this is from the AIS guide, and these are just some examples. The first row is the totally stable, the second is the incomplete posterior disruption, and the third row is the complete disruption. So these are all kind of looking down at a little bit of like an inlet view of the pelvis. But here you can see with the stable ones, it would be something like an iliac wing avulsion or an innominate bone avulsion. So this is like when a patient has a hamstring tear, a lot of times the hamstring will pull off a little bit of the ischium. So technically the pelvis is injured, but again, that posterior part is completely stable. This one is a little bit confusing because I talked about the sacrum and how that's part of the posterior ring. But you can see here that if you're very low on the sacrum or the coccyx, so like S4, S5, or the coccyx, even if that breaks off, the whole rest of the ring is stable. So we're mostly worried about the top half of the sacrum. The incomplete disruption, these are probably the most common ones that we see. So especially in the elderly patients, we see a lot of patients who had a fall and they have, you'll see on the radiology report, a sacral ala fracture. So it'll just be like a tiny little crack in the front of the sacrum, and they may have a symphysis, or sorry, a pubic ramus fracture in the front, but that tiny little crack in the back does not go all the way through. And in these, I think these drawings are a little bit confusing, but they really are looking at injuries where there might just be a partial damage to the ligaments in the APC or open book fracture, or partial cracking in the back, but not actually all the way out into a different zip code. So here you can see the really unstable ones have a 100% disrupted SI joint, or in this case, they actually have bilateral injuries here. So that's complete disruption of the posterior arch in the back. So the codes themselves, we really, I think everybody knows, want to avoid these NFS codes. So I'm just going to skip open. You guys know the difference between open and closed. I would just say that for the pelvis, the most common place that we see an open pelvis, especially in women, is that they have a vaginal laceration and it's open through that area. So if you see a vaginal laceration and a pelvic ring fracture, it may actually be an open pelvic ring fracture. So that's something to think about. But what you want to look at is using one of the following two codes if the fracture is stable. So again, the posterior arch is completely intact. Then we use the 856151.2 code, or 0.3 if it's open, which would be extremely rare because it's not a very unstable fracture. If we have a partially unstable, what you might see are the terms lateral compression, which we talked about pushing in, open book, which is that APC from the front and splitting open. The symphysis pubis may be separated, but again, we're not counting the number of centimeters because the posterior part is what's important, not the amount of anterior disruption. Sacroiliac joint anterior disruption or anterior compression of the sacrum. That's the sacral ala fracture that I was talking about that we see really commonly in the elderly. This says some bleeding may be expected with any pelvic fracture, but more significant hemorrhage must be documented to consider severity level increases due to blood loss. So again, with the more severe fractures, they have more chance to disrupt all those neurovascular structures that we saw at the beginning. So you may start to see patients who have large amounts of blood loss, and in that case, they may have one of these partially unstable fractures, but a large amount of blood loss, especially with a hematoma, and that's when you want to code one of these other higher level codes. With the hematoma, that's something that we usually see on CT. Sometimes you can actually see on x-ray when they do a bladder, they'll have a Foley catheter in, they inject dye in the bladder to see if there's a bladder injury, and instead of looking like a balloon, it looks like it's pushed over to the side, and that's because the pelvic hematoma has actually pushed the whole bladder over to the side. So that would be a moderate to large hematoma, so that's when you should definitely consider some of these other codes. And then the last one is the complete, totally unstable. So if you see vertical shear, sacroiliac fracture dislocation, or a displaced sacral fracture, then we're going to have these highest level codes for complete disruption of the posterior arch. And then again, if you see that blood loss, adding to that would be helpful, so we know they're also having bleeding from that pelvis injury. Okay, so I'm going to go on to the acetabulum classification, and then hopefully we'll have a few.
Question.
Oh, yeah, go ahead.
Dr. Miller, for confirmation, the sacral iliac fractures are partially unstable fractures?
Almost always. So if you see just the sacral iliac, usually will just be a little fracture in the front, unless you see that it goes all the way, we don't have a picture, sorry, but if you see a fracture that goes all the way through the sacrum, or if you see the words complete sacral fracture or displaced sacral fracture, then that would be complete or totally unstable. But if it's just a sacral iliac, the vast majority of the time, they're just going to be the partially unstable. Okay, so the acetabulum, again, similar pictures to what I showed earlier. We're thinking about the anterior column, anterior wall, posterior wall, and posterior column here. And on this view, which is what we mostly see on x-ray, this is the anterior wall. This is the posterior wall. The posterior column comes up from the ischium and along the back, and the anterior column comes along the superior pubic ramus. So these are those views like we showed earlier, that Jude view. And these are those same pictures where you can really see the outline of the posterior column and the anterior wall. Oh, sorry. And then this one shows the posterior wall, the anterior column, or here, anterior column and posterior wall. So these are the classification from the AIS. So the first level is partial articular, like most joint injuries, or one column. So it gets a little confusing because on the acetabulum, the partial articular and the one column go in the same classification. So partial articular would be posterior wall or anterior wall. So just like any other joint, only part of the joint is involved. So the posterior part or the anterior part. But the weird spinoff here is that this also includes the posterior column, which is same thing. It's just broken off like the posterior wall, but it's cracked all the way through the posterior column instead of just the wall. So on this picture, it would be the posterior column all the way through versus just that posterior wall part. So that's the first type, which is, again, partial articular or one column. The second type are partial articular and include the transverse. So the transverse fractures are very confusing because it goes all the way across. It includes the posterior column, the posterior wall, the anterior wall, and the anterior column. But we do not call it a both column fracture because when Jude, who again was French, so the translation gets confusing, but he called the both column fracture, the full name of it is actually an associated both column fracture. And it's a different definition than the transverse, which includes both columns, but we don't call it a both column fracture, which is very, very confusing. So if you have a transverse fracture or a T-shaped, which is a transverse with an extra crack that looks like a T, or the most confusing anterior column, which is just the anterior column, but add half of a transverse, so the hemitransverse, they count all three of these types as a partial articular transverse. And the only reason this kind of makes sense is because when you have a transverse or T, the upper half of the acetabulum is intact and only the lower half is involved. So it's only partial articular. And on this one, if you imagine the intact piece of bone that's still attached to the rest of the pelvis, still has a little piece of acetabulum in this corner. So that's why we call it partial articular. The other 3/4 of the acetabulum are broken off, but this little piece is still attached. And then you'll see on the final one, which is complete articular, for all three of these, if you imagine where the ilium is still attached to the rest of the pelvis through the sacrum, this is no longer attached to any part of the acetabulum in any of these fractures. So if you tried to trace the acetabulum, there's no direct contact between the acetabulum and the rest of the pelvis. And that's why they call it complete articular, because the complete entire articular surface is separated off of the rest of the pelvis. So gets a little confusing, but that's the main component that makes it different. So, and again, this is that transverse where even though it goes all the way through both columns, it's only a partial articular fracture because the SI joint is still attached to the top half of the joint. So this is how they kind of divide the fracture patterns. So a posterior wall, posterior column, and anterior wall, which we went over, are just partial articular. And then rarely you can get a posterior column and a posterior wall, which goes into the same category because it's just that same posterior part that's broken off. You also can have partial articular in the other direction, so the upper half is still attached, and that's these 5, versus the both column, also known as the associated both column fracture, which is where this part of the posterior SI joint and that posterior part of the ilium are no longer connected to any part of the acetabulum. So again, on this one that I showed you guys, the SI joint is intact, it's still attached to the posterior part of the iliac crest here, but this part of the acetabulum is no longer attached, and there's no part of the acetabulum that's still attached to the SI joint. So therefore, this would be that complete articular fracture. Okay. Any questions on that? I know the acetabulum part is extremely confusing.
There are a couple of questions. There's one about the ilioacetabular junction fracture. Is that coded to acetabulum, ilium, or both? And
Ilioacetabular junction. I don't know that I know that. Where did that terminology come from?
See if I can give Donna.
I would say it's probably more like this one, because the ilium acetabulum junction, I'm assuming what they mean is kind of the low greater sciatic notch fracture. So I would put that in the acetabular category, not the pelvis. But maybe if they could clarify a little bit more about what fracture they mean.
I'm trying to give you microphone access and it is not allowing me to. If you could email me, then I could forward that to Dr. Miller and we can try to get you a response within the next few days to a week.
I'd be happy to do that.
The other question was regarding, so I looked on page 145 in the AIS book, shows stable for sacral ala. And I don't see that, so I'm not sure which version of the book. Haley, do you have your book? I have the 2005 update 08, and on page 145, it's nothing to do with that. So Lori, if you also could send some additional, is it 115?
They're saying 2015 version.
Okay. I do not have that current version.
Which page? Sorry, what page number did they say?
Page 145 in the 2015 version of the AIS book has stable for your sacral ala or ala fractures.
Yeah, so I think it depends. If you look, I think I'm looking at the same page as you. So under stable, it says isolated simple or avulsion fracture of pubic ramus, ilium, ischium, sacral ala. So then if you look under partially unstable in the second box, it says anterior compression fracture of sacrum, including sacral ala fractures, if combined with anterior ring injury or pubic ramus fracture. So I can't say never because I'm sure there's somebody out there, but I would almost say I have never seen an isolated sacral ala fracture without a pubic ramus fracture. So in the extremely rare case that there was literally an isolated fracture of the sacral ala without an anterior ring injury, that is correct. It would be stable. But 99.999999% of the time, they're also going to have at least a pubic ramus fracture, a pubic root fracture, or a little something in the front. In fact, most people have something in the front and not something in the back, if anything. So that is correct, but it would be extremely rare to have an isolated sacral ala without a pubic ramus at all.
Thank you. It looks like those are the only questions. The PowerPoints will be handed out. So I will let Dr. Miller continue, and the other questions we will get to individually.
Perfect. So we have till 1, is that correct? Okay, so I will just go through a couple little quick case examples just so you guys have seen some of these x-rays. This is probably not as critical for you, but this is just an example of a patient with and how challenging it is sometimes to see these fractures. You might glance at this and not be able to see any fracture. But if you look at that Judet view where they tilt to the side, you can see that there is a little crack over here. And if you go back to the view from the front, you can see that there may be some kind of little disruption in that area where the posterior wall looks a little different than the other side. So here, this is just a posterior wall fracture, and this is what it looks like on the CAT scan. Sorry, I didn't have time to go over CAT scans, but when you do the axial cuts, you'll see that posterior wall, and you can see here a normal posterior wall looks like a little triangle on the end, and here it's kind of blunted because that piece has broken off, so that rest of the triangle is what's missing and that we have to put back. And this would be kind of the plate and screws that we use to put that back. So this would be one of the acetabular fractures that's just the partial articular or one column, but in this case, it's a partial articular fracture. This is an example of a posterior column, which again, very hard to see on the x-ray, but this whole piece essentially is broken off. And you can see on the Judet view where that posterior piece is kind of displaced out to the side a little bit more. So this one, we would also, again, put that back together with a plate and screws. But this would be, again, a partial articular or one column fracture because it's just the posterior column that's injured and the whole rest of the acetabulum is still nicely attached to the SI joint. This is a patient who has more of that transverse pattern where it kind of cuts through. One of my mentors used to say it's like a bandsaw went through the acetabulum. And in this case, the head has gone medial along with the inferior part of the acetabulum. But the upper part of the acetabulum, you can see here, is still connected to the SI joint and everything. In this case, there's a little bit of an interesting finding. If you look closely, this SI joint on the right side is actually a little wider than the left side. So this is a pretty unusual situation, but with the transverse fracture pattern of the acetabulum, that is the most common pattern that we actually see a combination of a pelvic ring injury and an acetabular fracture. So in this case, the patient would have both partially unstable pelvis fracture coating and transverse or partial articular, the second category of acetabular fracture coating. And in this case, we would have to fix both the acetabulum and the pelvis. And this is just a 3D version of that where you can see how the head went medial and look at all those neurovascular structures that are at risk in that area. So this is the CT of that same patient. You can see the head is here. The rest of the acetabulum is over here, so the head is in the wrong place. But what we have to do is pull this part of the acetabulum, which is the lower half, back over to the right place to get it secured again. So you can see this patient had an SI screw in the back to hold the pelvis part together, and you can see that here, and plates and screws to hold the rest of the acetabulum together. So they had both of their injuries fixed. This is another little similar one. So you can see the dome of the acetabulum here, and the head has gone medial. So again, this is kind of like that transverse bandsaw cut through. In this case, not a major pelvis injury to go with it, just the acetabular fracture. So this again would be that second category of transverse partial articular acetabular fractures. These are just the other images, and this is kind of what the CAT scan looks like. So this is actually one of those anterior column posterior hemitransverse that we talked about, but it still goes in that same category. And this gets fixed with plates and screws also. This is one of my partners, so he likes the inverted x-ray images. And I think this is the last one. Kind of a confusing image here, but you can see there's a fracture here through to the acetabulum. The patient also has the inferior and superior pubic fractures, and the symphysis looks a little funny. So this is probably another one where you would want to code potentially the pelvis injury and the acetabular fracture. In this case, if you look, the SI joint would be back here. So this is the intact ilium that connects to the SI joint. And if you follow that down, what you find, this is the intact ilium. And if you keep going down, there's no joint attached to it. So in this case, none of the acetabulum is still attached to the SI joint and the intact ilium. So therefore, this would be the complete articular fracture. This is an associated both column fracture. So it gets everything fixed. And I guess once we got in there, I don't remember, but the symphysis must have been pretty stable, so we did not have to fix the symphysis. And then this is just one final patient back to the pelvis side. This is a patient of mine who is on a motorcycle. So again, you can see that split in the symphysis where they hit the gas tank and then it split open. So this patient actually had bilateral SI joint injuries. And here you can really see the edge of the SI joint here and here. So it's very wide over here. So this whole side has a complete disruption. He also had an amputation on this leg, and then a more minor widening of the SI joint on the other side. So this is a very unstable pelvis. We actually had to put an X-fix on him and put screws through the whole thing because he was bleeding. You see all these little coils in here where they had to do vascular interventional radiology, had to stop bleeding in his pelvis because he was actually bleeding to death. And he ended up doing really well, but we leave that X-fix on for about 6 weeks, and then we can take that off once he is more healed. So this is him at his 1-year follow-up, and you can see the level of the amputation on that leg. Final case, this is another pelvis. This is an extremely obese patient, so that actually makes it much harder to see the x-rays, as you can tell. But here you can see the entire left side of the pelvis is pulled off. There's a sacral fracture here that's very wide. So you have to remember all those neurovascular structures getting stretched. And the symphysis, of course, is very wide. He also had multiple other lower extremity fractures, but you can see how huge that gap is for his sacral fracture. So obviously a complete posterior ring injury, and he would be the highest level of pelvis coating. He also had quite a lot of blood loss. Sometimes you can even see the hematoma, like we talked about, either pushing the bladder or pushing the bowel on the CT scan. So we ended up putting him back together with screws in the back and a plate and screws in the front. and he actually healed up pretty nicely. My partner called him a polar bear because he was obese, but he was actually a massive guy, like 7 feet tall, just a huge individual. So interesting having me as a surgeon. I know you guys haven't met me, but I'm only 5'3", so it's always funny when my patients are twice as big as me. So that's it. Happy to answer more questions. I know we're a few minutes over, but appreciate all of your interest and patience with the little snafus there.
That's okay. It looks like there's a question about whether if the orthopedic surgeon doesn't relate stability, can you still code unstable based on the diagnosis? I would think that you need to look at your AIS coding book. I'm sorry, I don't mean to take your presentation, Dr. Miller, but please chime in if you don't agree. I think looking at your coding rules within your AIS book and understanding the type of fracture that is documented, whether you have the descriptor of stable or unstable, would allow you to assign the appropriate code, which would therefore be stable or unstable. The same thing goes for your ICD-10 coding.
Absolutely agree. And do not trust your orthopedic surgeons to say stable or unstable. So you absolutely have the power to say it's an unstable code, even if the surgeon didn't say that. But again, as Amanda just said, you have to base it on the reads in the chart, things like the X-ray read or the terminology that's used in AIS, like having a complete sacral fracture or a complete SI disruption. Those are the things that tell you that it's unstable. But yeah, we've learned, we're actually doing a study on this right now about how bad orthopedic surgeons are at using the terminology that's helpful for you guys to do the correct coding.
Yes, hopefully you can get some luck changing that. We appreciate you. There are lots of thank yous and excellent presentation comments coming in, and how informative this presentation was. I thoroughly enjoyed it. It was hard for me to watch the chat and look for questions because I was wanting to watch. We did try to record this, everyone. It will be out on our TRAM YouTube channel if the recording and transcription worked the way it should. So fingers crossed, it will be out published for tomorrow. If you want to go out and look at the site and review it again, or look through it and watch Dr. Miller present again. We have 2 more sessions in our spring season, June 14th and July 26th. And then August, we move back into our fall sessions. We will have 4 fall sessions, and then we will have 1 winter session in December. So if you have not registered for those, please do so. If you have any questions, please reach out to me, Amanda Truelove, at bjc.org. You could also reach out to Haley Bolliard at SSM or Jacqueline Goodo. Those emails and contact information should be available on each of the sites when you go out to register. If you have questions on registration, please reach out to me and I'll be glad to work through helping you get registered. Thank you, everyone, and thank you so much, Dr. Miller. You did a fantastic job, and it was a delight to hear you present. I think we should hear you more often. I know you're busy, but it was a great presentation. With that, we will end today's session and let Dr. Miller get back to clinic and what she needs to do for her busy day, putting all these polar bears back together, as she said. Thank you, everyone, and we will see you for the next session in June.
Thank you.
Bye-bye.